Hi, my name is Tiffany Park and I'm a final year midwifery student with ACU Melbourne, and welcome to my presentation. Today I'm going to take you on a journey filled with evidence-based information, expert opinions and recommendations to guide future practice. Many of you listening today have most likely encountered this situation with women in your care, and I chose this topic because I too have witnessed this far too many times. I hope you enjoy my presentation on the impact on midwifery practice and maternal wellbeing in regards to the management of women's early urge to push prior to full dilation. The research aims for this literature review was to explore research and evidence on the incident rate and perceived implications of the early urge to push, to provide an overview of what management techniques are used to help women cope with an early urge to push prior to full dilation, to consider the impact current practice can have on maternal wellbeing, and make recommendations to guide future practice and prompt further research on the topic. The literature review was conducted using the databases shown on this slide, as well as clinical guidelines, midwifery textbooks, and expert opinions to identify relevant and eligible literature. The key search terms used were early, urge, push, involuntary, and labour, in combinations such as early urge to push and involuntary pushing in labour. It became evident throughout the literature search that much of the key research was published over 2 decades ago. Therefore, the search date parameters were extended to include articles from 2002 to 2021. The early urge to push is characterised by involuntary urge to push or bear down prior to full dilation. It occurs when the presenting part of the fetus descends and applies pressure to nerve receptors within the pelvic floor muscles. This sensation can be quite overwhelming for some women, and it's at this point in the labour progress that midwifery practice requires compassionate, woman-centred care and competent clinical judgment. I want you to take a moment and consider this common clinical scenario. You are caring for a woman in active first stage of labour. She is mobile and breathing beautifully through contractions, so you believe she is progressing well in her labour. At the peak of her next contraction, you notice some changes in her body language and vocalisation. You can see that her positioning has shifted and she is involuntary pushing, which indicates she's transitioning to the second stage of labour. She expresses that she can no longer breathe through them and needs to push with each contraction. You offer a vaginal examination, and with her consent, you find she is 8 to 9 centimetres dilated. I want you to have a think about what your management would be in this situation, and we will revisit this scenario later in the presentation. Things to consider here are: you have developed continuity with this woman. You have been continuously present in the first stage of labour. You have seen the changes in her behaviour, body language, and vocalisation, and believe she may be transitional. And that vaginal examinations are extremely subjective and should be considered in conjunction with the whole clinical picture. The decisions you make next can alter the course of this family's birth experience and significantly impact maternal wellbeing if not managed appropriately. In the past, the early urge to push has been reported as a pathological event, highlighting an increased risk of cervical trauma, oedema, tearing, hemorrhage, and maternal exhaustion. However, the concept of the early urge to push has more recently been considered a physiological process of labour in the absence of fetal or maternal compromise. Yet the optimal approach to management remains controversial and can vary dramatically depending on the care provider. A lack of quantitative research exists regarding the early urge to push in labour, with majority of the recent research available being observational, focusing on midwives' experiences and management decisions of the early pushing urge. Research from this literature review identified 2 dominant management approaches. 1, the hands-off approach, allowing women to labour entirely by instinct. And 2, a complete discouragement of pushing unless the cervix was diagnosed fully dilated via a vaginal examination. In 2013, Borelli et al.'s research was set in an Italian maternity hospital over a 6-month period. They noted that 60 women, 44 prima gravida and 16 multiparous, experienced the early urge to push prior to full dilation, resulting in a 7.6% incident rate. This result indicated that the early pushing urge was more prevalent in first-time labourers. They also reported that an early urge to push diagnosis of less than 8 centimetres dilated was linked to an increase in medical intervention, in particular the mode of birth and consequently the perineal outcomes. This study concluded that overall, the early urge to push is a physiological variation in labour and that midwives can suggest positional changes and breathing techniques to help women cope with an early urge to push. But without current policy or guidelines, limitations to care remains. Thus, a qualitative analysis of women and midwives' personal experiences in relation to the early urge to push was recommended. Midwife, academic, author and researcher Dr. Rachel Reed states that spontaneous pushing prior to full dilation is a physiological adaptation and helps women reach the second stage of labour faster. As an occipito-posterior position of the fetus is commonly recognised as a main contributor of the early urge to push, with Reed suggesting that the additional pressure can assist in rotating the baby into a more optimal position and assist with cervical dilation. With limited evidence showing the effects of the early pushing urge on the cervix and with a considerable number of women experiencing it, best practice should be based off an individual approach to intrapartum management. Midwifery practice needs to consider the impact management techniques can have on women during labour. A 2016 qualitative study by Celestia et al. Interviewed women in the postnatal period who had reported an early urge to push during labour to discuss their experiences and perceptions. The findings from the interviews were presented as 3 main themes. 1. A woman's perception of the early urge to push. 2. Bodily sensations versus midwife's advice and the struggle between conflicting messages. And 3, the feeling of trust about midwife's guidance during the early urge to push. After consenting to a vaginal examination and finding that they were not fully dilated, women reported that difficulty in following care providers' instructions to stop pushing due to the conflict it caused between their normal physiological sensation and trying to follow direction. Not surprisingly, women were quoted saying, "At that moment, the midwife was telling me to hold back the pushing and to blow and breathe to allow the contraction to go away, but I simply couldn't do that." Another woman stated that, "It was such a strange thing because no one believed me. My body was telling me to do one thing and I was being told to do the opposite. My husband didn't understand me either. He kept on saying, 'The midwife told you to stop pushing. Listen to the midwife.'" Dr. Rachel Reed stresses the importance of avoiding the implication that women's bodies cannot be trusted and states that discouraging women from instinctively pushing can lead to distress, a lack of trust, and disempowerment. Borelli et al. 2015 adopted a mixed method approach using a quantitative observation to investigate midwives' approaches to the early urge to push and a qualitative approach to gain a comprehensive understanding of midwives' views and experiences of management strategies. In response to an early pushing urge, midwifery practice appeared to be guided by parity, dilation, maternal exhaustion, presence of physiological signs, and respect for physiological times. Both dilation and parity were considered the 2 main determinants in the decision-making processes, with midwives more willingly adopting a stop-pushing approach for primigravida women. Conversely, in the presence of timely progress, a soft cervix, and without fetal distress, midwives would allow multiparous women to be guided by their own instincts. The study concluded that best management is for care providers to adopt an individualised care approach centred around empowerment and emotional support. In a bid to reduce childbirth trauma, Reed et al. In 2017 completed an online survey of 748 women, revealing data relating to care providers' actions and interactions during childbirth. The mixed method study reported that women felt their needs were overshadowed by care providers prioritising their own agendas, resulting in unnecessary intervention. It was concluded that when women's embodied knowledge about their labour progress was disregarded, it significantly impacted their birth experience, increasing the chance of childbirth trauma. They concluded that supporting women in labour to be guided by their own innate urges results in better birth experiences and therefore improved maternal wellbeing. Throughout the literature, it was reported that most midwives would encourage positional changes and breathing techniques to avoid pushing prior to full dilation. It was further noted that the use of water immersion and vocalization were used as alternative techniques to help women cope with an early urge to push. Data from the Borelli's 2015 study also identified that 15% of the 60 women who experienced an early urge to push were recommended an epidural to avoid causing cervical edema. This is an extreme intervention considering no evidence exists to support the claim that early pushing causes cervical trauma. Regardless of the techniques used by practitioners in an attempt to help women cope, it was reported that women felt it was virtually impossible to stop an involuntary, uncontrollable urge generated by hormonal interactions and physiological changes within their body. And asking women to do so can only lead to increased maternal distress, disempowerment, and a higher risk of medical intervention, all leading factors relating to childbirth trauma and decreased maternal wellbeing in the postpartum period. Cervical trauma and edema from early pushing is fast becoming the cultural norm within the maternity care, and an ongoing factor that negatively impacts maternal wellbeing. Most of the literature reviewed found no evidence that pushing prior to full dilation causes cervical trauma or is harmful to the progress of labour. In fact, it was Reed et al. 2017 who reported that the additional pressure generated by the early pushing urge can assist in rotating the baby into an optimal position ready for birth. They also stated that discouraging women from instinctively pushing can lead to distress, a lack of trust, and disempowerment. Due to the lack of evidence supporting cervical trauma from early pushing, many experts agreed that in the absence of all other maternal and fetal compromise, if a woman is experiencing an early urge to push at equal to or greater than 8 centimetres dilated, then her instinctive behaviour should be encouraged. Considering these recommendations, care providers should reflect on their management and how it can influence women's experiences of birth and impact on maternal wellbeing. So what was concluded from this literature review? That the optimal management of an early urge to push prior to full dilation is still disputable, with little evidence or guidelines underpinning practice. However, best practice should be to adopt an individualised care approach that is tailored around the women's progress, parity, and embodied knowledge. In the absence of maternal and fetal compromise, women should be encouraged to follow their innate behaviours and be guided by their instinct and self-belief to avoid this cascade of disempowerment and poor maternal wellbeing. Recommendations moving forward include more robust studies on the optimal management of the early urge to push in association with different dilation ranges, and the relevant clinical picture should be investigated. More research into the characteristics and mechanisms of the early urge to push is needed to enhance our understanding and help guide our practice to better care for birthing women. Having heard all the information presented here today, did you recognise the common theme identified? Let me recap once more for all you amazing midwives. Best management is for care providers to adopt an individualised care approach centred around empowerment and emotional support. Even with the consideration to parity, dilation, and maternal exhaustion, women should be encouraged to follow their own instincts so long as there is no fetal or maternal compromise present. By doing so, we can help create better birth experiences, facilitate empowerment, and therefore improve maternal wellbeing in not only the intrapartum and postpartum period, but for subsequent pregnancies for all women. With every birth, regardless where it takes place or how it happens, there is an opportunity for the mother to step into her instinctive, mammalian knowing and give birth like the goddess she is. Thank you for your time, and I hope this information can help positively impact your midwifery practice.